So it'll be a miracle if I get through this lecture without being interrupted by one of my mobile phones. I'm really sorry. So this is the second lecture on endometrial cancer. It's aimed at medical students, those taking the MRCOG, anyone else who's interested, but it does contain a few technical terms. Endometrial cancer 1 covers the pathology, including the instance and the age, and a few definitions. I didn't think anyone could sit through more than 15 minutes of me drilling on, so this is why I split it into 2 lectures. As stated in my previous lecture, I'm going to load this up on YouTube. I intend to put it up on my website, which is gynecologist.me.uk, along with the handout, which covers both this and the previous lecture. So we talked about definitions in lecture 1 and the pathological aspects in lecture 1, and this is really concentrated on the clinical aspects. So I'm going to start with diagnosis and investigations. I'm going to start with presentation. So the normal presentation is that of postmenopausal bleeding. So when I was a medical student, if you didn't investigate postmenopausal bleeding and you were asked that question in finals, you knew that you were on pretty dodgy wicket, and that was a pass-fail question. So postmenopausal bleeding is cancer of the uterus until proven otherwise. Abnormal menstrual bleeding is also an indication for investigations, but as the incidence is so low in women under 40 years of age, remember from the last lecture it was less than 1.2%, it's normally reserved for women over 45 or over 40, depending on your protocol. And on some occasions, women have an ultrasound scan for other reasons and are found to have a thickened endometrium. It might be picked up coincidentally on scan. It's really an issue in postmenopausal bleeding because premenopausal women, we don't really know what the thickness should be. So, investigations. So when you've decided you want to investigate it, hysteroscopy and curettage is the gold standard for diagnosis. Dilatation and curettage, just an old-fashioned DNC, used to be the gold standard, and it's still used in some countries who don't have access to hysteroscopy. So here is a video. This is a video of a hysteroscope, and you can see here in the top left-hand corner a tumour at the time of hysteroscopy, and that is biopsied. So, in terms of investigations, you've made your diagnosis. One of the investigations we would do, certainly in the UK, is an MRI. It's not universally available, but where it is available, it's used to assess myometrial and cervical invasion preoperatively. In addition, it can be used to assess lymph nodes positivity. It's not 100% sensitive, but can be used as a guide to surgery. And an MRI is as good as predicting myometrial. It is not as good as predicting myometrial invasion when they're fibroids. CT scan, it's normally recommended to look for chest metastases. It's obviously a lot quicker to have than an MRI. So often we do an MRI of the pelvis and a CT of the chest and the abdomen. It's good for looking at pelvic and paraortic lymph nodes too. Transvaginal ultrasound scan might detect a suspicious lesion in the endometrium, but can also rule out the possibility of endometrial cancer. When the endometrial thickness is less than 5 millimeters, that really rules out endometrial cancer. It also has the benefit of assessing the ovaries, and an abdominal pelvic ultrasound can be used to assess other extrauterine pelvic and abdominal disease. Some organs have used both transvaginal ultrasound and transanal ultrasound to detect myometrial invasion, but not all centres are skilled at that. Preoperative investigations. Well, women with endometrial cancer often have considerable comorbidity, as the condition is associated with obesity, hypertension and diabetes. Prior to any treatment regimen, it's essential that women are optimized for surgery or other treatments by ensuring their comorbidities are properly diagnosed and treatment. For example, an echocardiogram may be required to look for cardiac function in women with hypertension or other cardiac disease. Treatment. The primary treatment for endometrial cancer is surgery. Staging occurs at surgery for this reason. Now, some patients are not fit for surgery to a large amount of comorbidity, such as diabetes and obesity. And systemic medical treatments such as chemotherapy and hormone treatment can be used for high-stage disease. Of course, staging really occurs at the time of surgery, but you can do a staging at the time of imaging to select people out in that situation. It's generally agreed that care should occur in a multidisciplinary team in a specialised cancer centre, except perhaps for very early cancers, which are perhaps grade 1 or stage 1A on MRI. So, surgery for endometrial cancer, as I said, is the mainstay of treatment. It normally involves removal of the womb and the cervix, the tubes and the ovaries, and some form of lymph node assessment, either a lymphadenectomy or a lymph node sampling or a sentinel lymph node dissection. Pelvic lymph node dissection of some sort is normally considered, but there is a 15% of lymphedema or leg swelling of lymph tissue which is permanent when doing this. There's also a risk of lymphocysts, which is cysts in the pelvis from lymph tissue which can get infected and cause pain. And of course, when doing a lymph node dissection, you can damage the genitofemoral nerve, which can cause numbness around the leg and the thigh. You can damage the obturator nerve. Now, the obturator nerve, I always learnt at medical school, was the virgin's friend. It's involved in keeping your legs together, and that can cause weakness in doing that. There's a low risk of positive nodes if you've got a grade 1 stage 1A lesion, so it's normally admitted in grade 1 lesions, which are grade 1 on the diagnostic specimen at hysteroscopy and suspected stage 1A on MRI. So sentinel lymph nodes have been gaining quite a lot of interest at the moment. It's been a particularly personal interest. Most people feel sentinel lymph node dissection is appropriate with type 1 endometrial cancers. Still some controversy with type 2 endometrial cancers. So the steps involved in a sentinel lymph node dissection involve injection of a dye into the cervix. The most common dye is indocyanine green, which is looked at with infrared light, but there are other dyes such as methylene blue, patent blue, radio-labeled technetium, or a combination of those. And you remove the first 1 or 2 lymph nodes in a chain. And then when you remove it, you have to do something called an ultra dissection or a micro dissection. So it's a much finer, more time-consuming dissection of the node. As well as that, you remove any abnormal node seen at the time of surgery or at the time of imaging. And then if you don't get a sentinel lymph node, a full lymphadenectomy is required on any side where you don't find a sentinel lymph node. The role of periotic lymphadenectomy is also controversial and is more common in the Americas than in Europe. With the advent of sentinel lymph node dissection, however, this is decreasing, as it often defines when a periotic lymph nodes need to be sampled. Others recommend periotic dissection when there is type 2 disease. But this is controversial at the moment, and I wonder what this lecture will be like in a few years' time. It's usual during the operation for endometrial cancer to take washings that involves filling the pelvis with saline, swilling it around a bit and aspirating the fluid and spinning this down for cytological analysis. Although washings are still usually performed, they no longer form part of formal staging. Some surgeons will also take a mental biopsy in high-risk cancers, and that's what we do in our centre. it's normal to inspect as much of the abdomen and pelvis as possible with the laparoscope. And that's the clue in terms of surgical approach. Where possible, a laparoscopic approach is associated with less complications with open surgical approach. And this can be done using traditional instruments or with a robot. There is really good evidence now that laparoscopic hysterectomy, either using standard instruments or a robot, is associated with a lower risk of complications, especially wound complications. So obviously the complications, well, infertility, that goes without saying because you're taking out the uterus, but it needs to be put on a consent form. Menopause is the same because you're taking out the ovaries in a non-menopausal woman. That will make them menopausal, but you need to put it on the consent form. Bleeding, obviously requiring a blood transfusion or significant bleeding, about 1%. Infection of the wound, pelvis, chest or urine, really anything you touch can get infected. Injury to nearby structures, blood vessels, bladder, ureter. And what I'm putting up on the screen is an excerpt from our own consent form in my own institution, which is wrong.
I don't know that.
Sorry, that's Alexa that's just gone off there. What I'm putting on this is a consent form, which is in our own institution, which is the Royal Marsden Hospital. So then there's blood clots or thromboembolic disease, and the most common complication that is potentially fatal is a deep vein thrombosis or a pulmonary embolus. Pulmonary embolus is about 1 in 400, and that's very important. There's a risk of conversion to an open approach, and if not possible to complete surgery via laparoscopy, it may be required to open, either repair injury to nearby structures or just because it can't be completed laparoscopically. The risk of this in the GOG LAP2 trial was 15, actually I think it was nearer 25%. In our own institution it's nearer 4%, but you remember in the GOG LAP2 study they recruited all comers and it involved periaortic lymphadenectomy. Incisional hernia, if you have an open operation, it's probably about 15%, very high risk, and it's one of the reasons we do it laparoscopically. We've already talked about lymphocysts and lymphedema. On our consent form it says that less than 5%, but in fact a more recent study has shown that it's nearer 15%, and we have a specific lymphedema team in our institution. Return to theatre, either because of risk to other structures or bleeding, and the overall risk of serious complications, which is, if you recall, complications are classified according to the Clavian-Dando criteria, and you might want to look that up. It covers all surgery. It's about 4%, and there's a risk of death. So you've operated on a woman, you now have to decide who has adjuvant therapy, and that can be in the form of radiotherapy, either in the form of brachytherapy, which is delivered through the vagina, or in the form of EBRT, external beam radiotherapy. Brachytherapy is usually in the form of 2 to 5 treatments, and EBRT involves daily treatments for 5 weeks, normally to a dose of 45 gray. Now, I'm a surgeon and we think it's very amusing that brachytherapy, it only needs to be delivered on a Monday to Friday and not on a Saturday and Sunday or bank holidays. Anyway, the potential complications of radiotherapy can be quite severe and include radiation cystitis, radiation vaginitis and radiation enteritis. This can obviously affect people's quality of life. So we often do give these patients chemotherapy now. It's used for advanced metastatic and some high risk cases of endometrial cancer. It's usually in the form of carboplatin and paclitaxel. This is changing a lot now with the advent of immunotherapy, and I suspect that this will be out of date quite quickly. Some women can't really accept paclitaxel due to the severe side effects of tiredness, malaise, hair loss, and they receive single-agent carboplatin. Hormone therapy has been used for conservative treatment, and I'm going to detail this in another slide, but it basically involves high-dose progesterones or GnRH analogues. They've all been reported on. Some people have reported on the Mirena. It's interesting, I'm currently in the COVID epidemic or pandemic now, and we're trying to prioritize people. Now we're in our peak, because we know that if we delay things for 3 months, we'll have more access to ITU beds. And so we are prioritizing our grade 1 cancers who we think are stage 1A on MRI to receive high-dose progesterones. But this has been predominantly used for fertility-sparing surgery up until now, and it's for women with grade 1 endometrioid and stage 1A on MRI. And we give them 400 to 600 milligrams a day of medroxyprogesterone acetate. It's a very high dose, and not all women can tolerate this, or 160 to 320 milligrams of Megestrol. Obviously, you need to remove the estrogen trigger. So if you remember back to the previous lecture, you must tell these women to lose weight, and really all weight loss options need to be explored, including bariatric surgery. I think if women have progesterone treatment, they do need to be told that it's not conventional treatment, and a hysterectomy is required on completion of their attempts to conceive, whether they've been successful or not. And while they're ongoing on it, they need to have at least 6 monthly hysteroscopies until they have a hysterectomy. If it doesn't reverse the cancer at 6 months, they should have a hysterectomy. Pregnancy rates are about 25%, increasing to 40% if you use assisted reproduction techniques. And the response rate, in other words, no cancer after 6 months, is 75%. But the recurrence rate is high if they don't subsequently have a hysterectomy, which is 30 to 40%. So other treatment considerations, well, these include supportive care. Obviously, in a multidisciplinary team, we have our clinical nurse specialists, dietary advice, because we want these women to lose weight, physiotherapy, psychological support, psychosexual support. Obviously, we have great emphasis on our clinical nurse specialists in the UK, and then, of course, at the very end, palliative care. So I'm coming back to this lecture now, having had to pause just for a second because my phone went off. So I'm going to talk about the ESGO risk groups. They include low, intermediate, high intermediate, high, advanced, and metastatic. So low is stage 1, grade 1 to 2, less than 50% myometrial invasion and lymphatic space invasion negative. Intermediate are those with either 50%, well, that is the same, but with more than 50% myometrial invasion, in other words, stage 1B, grade 1 to 2, with lymphatic space invasion negative. High intermediate is when they're lymphatic space invasion positive, grade 3, but less than 50% myometrial invasion. Stage 1 with grade 1 to 2, whether it's lymphatic space invasion positive, irrespective of myometrial invasion. High risk ESGO groups are stage 1 endometrioid, grade 3, with more than 50% myometrial invasion, whether they're lymphatic space invasion positive or negative. Stage 2, stage 3 endometrioid with no residual disease, and non-endometrioid pathology, uterine serous papillary or uterine papillary serous, clear cell, undifferentiated carcinoma or carcinosarcoma. Advanced is stage 3 with residual disease or stage 4A, and then metastatic disease are the stage 4Bs. So this is just an example of a treatment protocol that we have at the Royal Marsden Hospital. It's on the handout, so you don't need to go into it in great detail, but it just shows when and how we offer adjuvant treatment, whether we offer brachytherapy, for example, with stage 1B disease, when we push in EBRT, and when we give them chemotherapy. For example, when we have a high-risk pathology or node involvement. So in this chart, which is on your handout, VBT stands for vaginal brachytherapy and EBRT stands for external beam radiotherapy. Different institutions have different protocols, but every institution should have a protocol. So a few interruptions in that lecture. I don't think I can get through 15 minutes without having an interruption in my house, especially at the moment because of COVID-19. I hope you enjoyed Alexa, and I'm sure I'll do some more of these lectures. The end.